fusions, and at one go you can test for all of these. So these are the four various methods which are available, and each has its own pros and cons. Depending on, and the test which can be ordered will depend on the availability of these tests, type of the samples, generic alterations which are targeted, cost, and turnaround time, which is one of the most crucial component for deciding the therapy to the clinician. So these are just few recommendations for the turnaround time, which we as a laboratory person should keep in mind if you're using these various assays in your routine practice, right from the IHC to the various NGS based assays. About ALK and ROS, which are one of the common alterations, the FISH and IHCs are commonly used for the testing of these, and PCR based assays are not recommended. Just to give the examples, for the break apart gene probe is used for the detection of ALK and ROS, and if you see these break apart signals in more than 15% of the cells, it is considered to be rearranged for ALK. The IHC for ALK is one of the companion diagnostic assay which is approved by FDA, but can you use it without Ventana autostainer? The answer is no. So as it is one of the predictive biomarkers, so you have to use this only with the Ventana platform. The trends of IHC testing by ALK is increasing, and at the same time the number of the requests which come for the FISH testing is reducing day by day. ROS is another common biomarker which is being tested by using IHC, and these are the two common clones which are available. But as compared to the ALK IHC, the ROS IHC can show the variable pattern of the staining, as well as the staining can sometimes be very weak or faint. And if you see the concordance between the FISH and raw FISH and IHC, so as compared to the ALK, although the sensitivity is quite good, but specificity is very variable. So the cases which show the strong and diffuse positivity, or the one which has a good H score of over 100, can show a good correlation with the FISH. So due to this limitations, all the cases which are screened by ROS, if they come out to be positive, need to be confirmed by orthogonal method. Another query comes, why do we don't use the PCR based methods in the routine clinical practice? The reason being, as you can see, there are multiple fusion partners, and at the same time, if you don't have a known targets, you are likely to miss these alterations. Just to throw a light on some rare alteration, red fusions, although the FISH was tried earlier, in the current era, NGS is the recommended method because IHC is not reliable for red screening. NTRK, although as we know the prevalence of NTRK in the lung cancer is low, and so if you can use IHC as a screening modality, but all the cases which are positive need to be confirmed by orthogonal method. MET fusions also rarely can be encountered, and if you are using RNA based NGS panels, it can give the opportunity to test for these alterations. So as we can see, there are a lot of these alterations are picked up by the next-gen sequencing methods, and it is now developing as a method of choice for detection of the fusions. But we have to keep in mind, if you are targeting only for the fusions, we have to see which gene panel we are using, and RNA based targeted approach gives a more reliable information about the fusions. But we have to also keep in mind the limitations of the RNA-based assays, because RNA is difficult to manage, and they can be compromised due to the quality as well as the quantity of these assays. Another important thing is for the NGS-based assays, we have to be familiar with which technology is being used for screening of these fusions, either whether it is a hybrid capture or amplicon-based assay, because each of them has their own pros and cons. The major advantage of amplicon-based assay is it can work with a low RNA input, which is very common practice with the lung cancer, but at the same time it can miss some of the unknown partners. So for that we have to be very careful. So we have to be concerned about there can be some concerns about the NGS based assays, and we have to keep them in mind, especially in terms of the quality of the tissue, the fear of false negatives, especially with the DNA based assays, and if the quantity of the tissue is less, how to manage these assays. So there are some problems, but there are at the same time the solutions are also available, and hence whenever you're seeing any report of the NGS using these NGS report, pay attention to these parameters, like which panel is being used, tumor content, how much it was their depth of the coverage, and ask for the cutoff criteria which is used to call any test as a positive. And if you are in a doubt, it's better to go for orthogonal testing. So again, to show you some snapshot of the various assays and the various fusions which are now into the clinical practice, and in future more and more testing by either by IHC or NGS based assays will be used in future. Thanks a lot for your patience hearing, and if there are any questions, I will be happy to take them.